Hello and welcome to Zoology 142 online. This is the lecture on the respiratory system. In today's lecture there are four main respiratory processes that we'll be talking about. The first of these is pulmonary ventilation, and that is basically the breathing that happens to bring air into the lungs and ventilate air out of the lungs. And those movements are accomplished by the diaphragm and also the intercostal muscles and sometimes even the abdominal muscles. The second process is external respiration. This is the movement of oxygen from the lungs into the pulmonary capillaries, and also the movement of carbon dioxide from the pulmonary capillaries into the alveoli of the lungs. And this process is facilitated by simple diffusion, which is the movement of gases from an area of high concentration to an area of low concentration. The next process we're going to talk about is transportation of respiratory gases. Basically, how do the gases get to where they're going? Once oxygen is absorbed in the lungs, it then has to be transported through the pulmonary capillaries into the pulmonary veins and eventually reach the systemic circuit. And the way that it does this is it binds to the hemoglobin molecule within our erythrocytes or red blood cells. We're also going to talk about the different ways in which CO2 is transported. The final process is internal respiration. This is simply the movement of oxygen from the blood into the systemic tissues and the movement of carbon dioxide from the tissues into the systemic blood vessels. Just like external respiration, the process of internal respiration utilizes diffusion. That is the movement of a gas from an area of high concentration to an area of low concentration. Because carbon dioxide is more heavily concentrated in the tissues, it tends to move from the tissues into the capillaries, whereas oxygen is more abundant in the systemic capillaries and is going to move from the capillaries into the actual tissues. And we'll talk more about each of these four processes throughout the lecture. So this slide just gives an overview of the major anatomical features of the respiratory system. There are basically two zones of the respiratory system, the conducting zone and the respiratory zone. The respiratory zone is the alveoli, that is exactly where the gas exchange is going to take place, and pretty much everything else is going to be the conducting zone. That is the hollow tubes that's going to get the air down to the respiratory zone, and it includes things like the trachea, the larynx, the nostrils, the pharynx, and also the nasal cavities. And we'll talk more about each of these in some detail. So the first division of the respiratory tract is actually the respiratory zone. This is the site of external respiration or gas exchange between the alveoli and the pulmonary capillaries. And the respiratory zone consists of the alveoli, the alveolar ducts, the respiratory bronchioles, and also the membranes of the pulmonary capillaries. So big picture here is the respiratory zone is the place where gas exchange takes place. On the other hand, the conducting zone is basically all the tubing that helps to bring that air from the outside down to the respiratory zone. So one of the questions you're going to look at on the exam is trace the path of inhaled air from the nose all the way down to the respiratory zone or the alveoli. And in order to get there, it has to go through the nose, the nasal passages, the nasal pharynx, eventually down into the larynx, the trachea, the bronchi, and eventually reaching the bronchioles and finally the alveoli. So all of these hollow structures that help to conduct air down to the alveoli are part of the conducting zone. So let's start at the very beginning of the conducting zone structures. When you breathe in, most of the time you're breathing through your nose. And the nose is obviously very important in functioning for smell, but it also has a function to help to warm and moisten the inhaled air. Within the nasal passages, we have something called turbinate bones or nasal conchae, and these are basically spiral membranes that have lots of mucosal epithelium on them. And as the air moves over this mucosal epithelium, it is warmed, it is humidified, and any particulate matter is trapped in the mucous membranes. And this helps to make sure that the air getting down to the respiratory zone is fairly clean, it's pretty warm, and it also has adequate humidity. And this is essential because the respiratory zone is made up of very, very delicate tissue, that is simple squamous epithelium. And it can be easily damaged by air that is too cold, too dry, or air that has a lot of particulate matter in it. So the way that we scrub the air of any particulate matter or bacteria that might be in there is by having a nice mucosal epithelium throughout the conducting zone structures. And so we have usually a pseudostratified ciliated columnar epithelium within the trachea, and the cilia here are moving the mucus around, and the job of the mucus or snot is basically to trap the particulate matter. and this mucus has a limited lifetime. It's only good for a few hours until it starts to harden, and so these cilia are going to wave it up towards the pharynx, where you're either going to cough it up and spit it out, or you're just going to go and you're going to swallow that mucus. Either way, you're helping to get any particulate matter that was in the air that you inhaled out of the respiratory tract, and you're disposing of it by either spitting it out or throwing it into the digestive tract. One of the next structures we're going to go through on our path from the nose to the alveoli is going to be the pharynx. The pharynx is a muscular tube which extends from the base of the skull to around C6, that is the sixth cervical vertebrae, and it helps to connect the nasal cavity and mouth to the larynx and also the esophagus. It is composed mostly of smooth muscle. And this muscular tube called the pharynx is further subdivided into three regions. The nasopharynx is the hollow cavity just above the soft palate in the back of the mouth, and so this is a place where we only find inhaled air. There shouldn't be any fluid or food here. Whereas the oropharynx is in back of the oral cavity, and this is a place where both food and air may be crossing. And finally, we're going to reach the laryngopharynx, which is located deep to the larynx. And the laryngopharynx is the place where we're going to sort out where the food goes that we eat and also where the air goes that we inhale. So ideally, food is going to go down the esophagus, whereas inhaled air is going to be routed down the trachea. And we'll talk about how that happens in just a few slides. The next structure we're going to talk about in the respiratory tract is something called the larynx. The larynx is basically the passageway or entryway into the trachea, which is our main respiratory tube. And so the larynx is composed mostly of cartilage, that is hyaline cartilage, and it has some major structures. The first of these is the thyroid cartilage. The thyroid cartilage is a very large cartilage that makes up the anterior aspect of the larynx, and it's also responsible for what we call your Adam's apple. So as the name implies, the thyroid cartilage sits very close to, but superior to, the thyroid gland. Below the thyroid cartilage, we have the cricoid cartilage. This is another very important supporting cartilage for the larynx. And finally, superior to the thyroid cartilage, we also have the hyoid bone. The hyoid bone makes up the superior-most part of the larynx, and again is important for supporting the larynx, although we should also point out that this hyoid bone is not really connected to any other bones in the body. And finally, another important structure of the larynx is something called the epiglottis. The epiglottis is another cartilaginous structure, but this cartilaginous structure is actually a valve. And the epiglottis helps to divert food into the esophagus and helps to make sure that the air that we inhale goes down the trachea. So it really is a miraculous valve. And here we can see a longitudinal section of the larynx. It's basically been cut open, so we could also call this a mid-sagittal section. Up top we see the epiglottis, and remember the epiglottis is a muscular valve that helps to divert food into the esophagus and also helps to make sure that air ends up going down the trachea. We have various cartilages within the larynx. One of these I want to point out is the vestibular fold, and this is not really cartilage, but it's actually made up of connective tissue, and we call these your false vocal cords. And then below that we have your true vocal folds, or true vocal cords, and again these are made up of fibrous connective tissue that is attached to skeletal muscle. And the skeletal muscle adjusts tension upon these folds so that when we pass air over the folds we generate sound. And because it's made up of skeletal muscle and connective tissue, we can voluntarily change the stretch in these folds and produce different pitches in our speech. You'll notice below the larynx itself that the trachea is made up of several tracheal cartilage rings. These rings are actually incomplete. They're more horseshoe-shaped, and in back of these rings we can actually see a small layer of smooth muscle. And we'll talk about the importance of this smooth muscle layer a little bit later on. Okay, we're now taking a look at the superior view of the larynx. That is, we're looking down into the larynx from up above. You can see the base of the tongue located at the top of the picture, as well as the epiglottis. Remember, the epiglottis is that very important valve that helps to prevent food from moving into the trachea, which would be very catastrophic, and helps to ensure that air goes down the trachea but food goes down the esophagus. Deeper to the epiglottis we can see our vocal folds, and our vocal folds are basically the passageway through the glottis. The glottis is basically the opening of the larynx into the trachea. And you can see in the left picture that the glottis is closed or covered by the vocal folds. So one of the important functions of the vocal folds is speech, but another one is forming a valve that can basically shut off the air leaving or entering the larynx. And we use this process when we're lifting something very, very heavy. So think about you're going to lift something very heavy, like a desk or something like that. You reach down to pick it up, and then you go like that. And that noise is actually made when you basically cut off the airflow from your lungs using your vocal folds. So basically, we're closing off the glottis. And this process is called splinting, and we use it to provide additional pressure and support within the thoracic cavity when we're lifting something very, very heavy. We also use it when we are straining to defecate. So think about the sound that somebody makes when they're on the toilet, particularly if somebody's trying to talk to them while they're on the toilet, and they're saying, "How's it going in there?" And you'll be like, "It's going fine." And that's because you're basically cutting off most of the airflow through the trachea and the larynx using your vocal folds. And again, this process is called splinting, and another name for it is the Valsalva maneuver. And the Valsalva maneuver helps us to generate a little bit of intra-abdominal pressure in order to get the defecation reflex going on. So remember that one of the big functions of the larynx is to produce speech. And speech is a voluntary process whereby we apply some muscle pressure via skeletal muscle onto these connective tissue vocal folds. And basically by adjusting the tension on the vocal folds, we can adjust the pitch of the speech. The loudness of your voice, on the other hand, depends on the amount and force of air that is leaving your lungs and entering your larynx. And so if you want to speak very, very loudly, you have to send a lot of air up through the lungs, where if you want to speak very, very softly, you're only sending a little bit of air through the larynx and across those vocal folds. Now, other structures within the respiratory tract are also important in enhancing the sound quality of our voice. One of these would be the chambers of the pharynx and also the nasal sinuses. The sinuses are hollow areas within the frontal bone and elsewhere in the respiratory tract, and they help to give us some resonating sound to our voice or our speech. And you can think how important this is when you think back to what your voice sounds like when you're very congested.
When you're congested, it's very, very difficult to understand somebody because their voice sounds very funny, and that's because of the amount of mucus that is plugging up the sinuses and so forth.
And so the sinuses are normally a very important chamber to help with the resonation of the voice as we speak. Okay, our next stop along the conducting zone will be our trachea. The trachea is probably the largest and most conspicuous of the conducting zone structures. It is a very long tube that extends from your larynx all the way down to the bronchi of your lungs, and it is composed of smooth muscle along with some C-shaped cartilage rings that help to hold it open or ensure its patency. The trachea is lined with a pseudostratified ciliated columnar epithelium. And remember, the purpose of that epithelium is to produce mucus and also to force that mucus up to the superior part of the trachea so that as it traps particulate matter, dirt, bacteria, eventually we're going to cough that phlegm up and spit it out, or we may just swallow it. And so the epithelium is very important for making sure that dirt and particulate matter don't get down to the respiratory zone. Okay, this slide just shows a histological section of the trachea, and this would be a transverse section. So at the bottom part, you can see the anterior part of the trachea and see that it's made up of hyaline cartilage. And this hyaline cartilage, even though we said is a ring, it's more of an incomplete ring or a horseshoe. If you look superiorly in the picture, you can see that that horseshoe is breached by a layer of smooth muscle called the trachealis muscle. And the trachealis muscle is very important for coughing. Imagine that you have accidentally inhaled a bug or something like that and it's gone down your windpipe or trachea. One of the first things that's going to happen is your body is going to stimulate a cough reflex to get that bug or whatever it is out of the trachea so it doesn't go down to the lungs. And so when you cough, you will have a lot of air being forced through the trachea, but at the same time that trachealis muscle will contract violently. And think about what that's going to do to the diameter of the lumen of the trachea. It's basically going to restrict the size of the lumen, and by restricting the size, we're going to create an increased pressure. And this increased pressure is very important for forcing any particulate matter or something you've accidentally inhaled out of your trachea back into the pharynx, and hopefully you're going to spit that out. Now, the next thing I want to point out before moving on to the next slide is that above the trachea there, you can see the lumen of the esophagus. The esophagus is the passageway for food, and unlike the trachea, it's not supported by any types of cartilage rings. In fact, the esophagus is usually closed off except when we're swallowing something. So if you're looking at somebody that's standing up, their esophagus is actually going to be in back of their trachea. The trachea or windpipe is actually the structure that you feel on the front of your throat, and the esophagus is in back of that. So big picture here is that the trachea is reinforced with these hyaline cartilage rings to maintain its openness or patency, whereas the esophagus is just a smooth muscle tube that doesn't have any cartilage in it whatsoever. And that's because the esophagus is normally closed except when we're swallowing food. Okay, after the trachea, we're going to branch off and form the bronchi or bronchi. We have what we call primary bronchi, secondary bronchi, and also segmental or tertiary bronchi. So take a look at this picture. Here you can see the trachea branches off, and we have a left and right primary bronchus. The primary bronchi branch off to form secondary bronchi, and the secondary bronchi will branch off to form several segmental or tertiary bronchi. And so as we get lower in the respiratory tract, the bronchi get both smaller and also more numerous. In addition, the composition of the bronchi change radically as we go from the trachea down to the respiratory bronchioles. One thing we're going to see is the amount of cartilage actually decreases as we get further down in the conducting zone. The trachea was reinforced with these big cartilaginous rings, whereas when we get down to the tertiary bronchioles, there's little, if any, cartilage in there, and it's primarily made up of smooth muscle. This gives us the ability to greatly adjust the airway diameter the further down in the respiratory tree that we get. So the trachea itself is not very adjustable, but the bronchioles and the tertiary bronchi are quite adjustable because they contain a large amount of smooth muscle. The other thing that changes is the epithelium type. Remember I said that the epithelium within the trachea was pseudostratified ciliated columnar. And that stays the same as we go down the primary bronchi, but as we get down to the tertiary bronchi, we now are going to have a simple cuboidal epithelium. So not as much mucus being secreted, we don't have the cilia that we had further up, but we do have an airway that can be greatly adjusted in diameter. So this slide just summarizes all the changes in conducting zone structures that happens as you move from the trachea into the primary bronchi, into the secondary bronchi, and then finally down to the tertiary or segmental bronchi. So if you need to review this material, pause the presentation here. Otherwise, go ahead and go on to the next slide. So now that we've had an overview of the major respiratory anatomy of the lungs, we're going to go focus again on the respiratory zone. And remember, the respiratory zone is the actual site of gas exchange between the pulmonary capillaries and the alveoli. And so the respiratory zone structures include the respiratory bronchioles, the alveoli, and also the alveolar ducts. And it also includes the membranes of the pulmonary capillaries. So big picture is that the respiratory zone is the site where external respiration or gas exchange takes place. Now in the previous slide you saw what was basically an artist's rendition of what the respiratory zone should look like, but this slide actually shows a histological section of the lung tissue, and so you can see that it looks a lot different. You can see on here that we have lots of little bubbles, some of which are broken open, and the bubbles are indeed the alveoli. The alveoli themselves are composed of a single layer of simple squamous epithelium, and so they're very thin and very delicate, but their thin membrane makes them very good for transporting our respiratory gases across this epithelium into the pulmonary capillaries. Now there are three main cell types that make up the respiratory membrane. The first of these are the type 1 cells. These cells are simple squamous epithelium, and they make up the walls of the alveoli as well as the alveolar ducts. And they're typically around a half a micron in thickness, and so they're very, very thin, and by having a very thin membrane, we're enhancing the ability to transport oxygen and carbon dioxide across the alveoli into the pulmonary capillaries. If this membrane was, let's say, 3 microns or 5 microns, the transport of oxygen and carbon dioxide would be greatly slowed. The next type of cells that we find within the respiratory membrane are what we call type 2 cells. These cells secrete something called surfactant, and perhaps you've heard of surfactant before. It's something that you'll commonly find on the ingredient list for things like soaps and laundry detergents, because surfactants help to break down the surface tension of water. you probably remember that surface tension is basically the tendency for moist things to want to stick together. And surface tension is very good for some things, but it could actually be detrimental to the function of the alveoli. Think about what happens when you get two wet pieces of paper very, very close together. What do? Well, they tend to want to stick to one another. And so now think about the sides of the alveoli. They're only about a half micron in thickness, and so they don't have much rigidity to them, and they're very, very close together. And they're also very, very moist. And so these three things make the alveoli want to collapse and make the alveolar walls want to stick together. And obviously this would not be good for respiration because it would close off our airway, preventing gas exchange. And so the purpose of these type 2 cells is to produce a little surfactant or soap-like molecule that can help break down that surface tension so that the alveoli remain open. And in a place like Hawaii, this surfactant is very, very important. If you've ever gone to Sandy's or Makapu or someplace like that on a day where the waves are really pounding, chances are you'll see somebody that's on vacation there and taking advantage of the beach and trying to do some body surfing or whatever. Maybe it's a day that they shouldn't be out there, but dadgummit, they're here from Wisconsin for only 1 week, and they're going to go body surfing if it kills them, and sometimes it does. Sometimes you'll see people that are pulled out of the surf. They haven't drowned, but they've ingested some water, possibly even gotten some water down into their airway. And so as the lifeguards are pulling them out, the ambulance rolls up. A lot of times this guy, because it's usually a guy, will basically cough up some water and then very quickly, sneak off and say, no, I don't want any medical care, because he's just so very embarrassed. And this is dangerous because if you've had any water down into your lungs, you can temporarily wash away some of that surfactant. And so we can have somebody that had a near-drowning experience, goes home, does not get medical care, and all of a sudden, an hour, 2 hours later, they actually drowned on dry land because the alveoli begin to collapse because there's a lack of surfactant in there. And this process of alveolar collapse is called atelectasis, and it can be very, very life-threatening. And so anytime we do have somebody that's had a near-drowning experience, we always encourage them to go to the hospital. We can give them some drugs, or we can just observe that person to make sure their airway stays open and those alveoli don't collapse, and also give them time for them to start manufacturing some surfactant so that the respiratory membrane will be stabilized. Okay, the last type of cell that we have within the respiratory membrane is something called the alveolar macrophages. Remember that macrophages were a part of our nonspecific immune defense. They're very generalistic cells that basically gobble up bacteria and particulate matter. And so because the respiratory system is basically a dead-end sac, there's the potential that bacteria and cellular debris can get washed down in the alveoli. And so it's the job of these fixed alveolar macrophages to gobble up this material and prevent it from contaminating the respiratory membrane. And finally, I should also point out the pulmonary capillaries. You can see the pulmonary capillaries at 6 o'clock and also at 9 o'clock, and basically they form a mesh network around each of the alveoli. And this is where the oxygen is going to move to once it crosses the alveolar membrane into the pulmonary capillary. Before we go on to the next topic, I just want to point out some external anatomical structures on the lungs that we haven't talked about yet. The first thing you should notice is that the left lung and right lung are both divided into lobes. And you can see that the left lung has only a top or superior lobe and a bottom or inferior lobe, whereas the right lung actually has 3 lobes, a superior lobe, an inferior lobe, and also a middle lobe. You can also notice within the left lung that there's a special dimple or notch there called the cardiac notch, and that just gives a little bit of room for the heart to sit. And finally, at the bottom there, you'll see the diaphragm. The diaphragm is skeletal muscle, and it's probably the primary muscle responsible for ventilating the lungs. We now need to touch on the blood supply to the lungs. If you remember from our last couple lectures, we talked about the blood vessels that bring deoxygenated blood to the lungs so it can be oxygenated. What were the names of these vessels? Well, if you said the pulmonary arteries, you're correct. The pulmonary arteries travel from the right ventricle and bring deoxygenated blood to the lungs so that it can pick up oxygen and drop off carbon dioxide. But because these pulmonary arteries don't have any oxygen to speak of in there, we actually have to get oxygen for the lung tissue itself from another location. And this source is from the bronchial arteries. The bronchial arteries provide the lungs with oxygenated blood for their own metabolic needs. Now, the lungs are surrounded by something called a pleural membrane, and this is analogous to the pericardial membrane that we saw around the heart. Basically, it's a thin serous membrane that surrounds the lungs, and one of the things it does, it prevents friction between the lungs and the thoracic wall. Like the pericardium, there is actually a small cavity within the pleura of the lungs, and this cavity contains a little bit of pleural fluid. Now, and sometimes during infections, we can actually get an accumulation of fluids or exudates within this cavity, and this can greatly reduce the amount of expansion that the lungs can do during ventilation. The other thing you should notice about the pleura is there's both a visceral and parietal layer. The parietal layer is the layer that touches the body wall, whereas the visceral layer is the layer that actually touches the lungs. And normally there's a negative pressure in between these two pleural layers, and this is called the intrapleural pressure, and it's around -4 millimeters of mercury. And this negative pressure is very important because it helps to hold the lungs and the pleura to the sides of the thoracic wall. If we have a loss of this intrapleural pressure, let's say by somebody getting stabbed with a knife or something like that, it can cause the lung to spontaneously collapse because air is let into the pleural cavity and thoracic cavity. And this process is called a pneumothorax, and it's a very life-threatening condition. So this slide just summarizes the two disorders I talked about previously. One of these was atelectasis, which is collapse of the alveoli within the lungs. It can happen on the level of 1, 2, 5, or 10 alveoli, or it can be something that involves the whole lung, and if it's the whole lung collapse, it's usually because of pneumothorax. Pneumothorax is atelectasis that occurs because somehow we've let air into the thoracic cavity. Usually in this case we say somebody has a sucking chest wound. That is, they've had something pierce the thoracic cavity and let air into it, and so that negative pressure that was holding the lungs open has now been lost, and now the lungs will just collapse in on themselves. And so pneumothorax, as you can imagine, can be quite life-threatening. And so in order to treat it, we oftentimes will stick a chest tube in that patient and draw out any excess air or fluid that's in the pleural cavity, and maybe provide some positive pressure in the airway as well in order to open the lungs back up and get the alveoli to open up. If not treated properly, pneumothorax can be a fatal condition. Okay, now that we've had an overview of the major respiratory anatomical structures, we're going to go back to those 4 or 5 processes that we talked about at the beginning of the lecture. The first of these processes is pulmonary ventilation, which is just basically the movement of air into and out of the lungs. And we call this inspiration if air is going in, and expiration if air is going out. And so this is a very mechanical process that depends on volume changes within the thoracic cavity. When the diaphragm bows downwards, this creates a greater volume within the thoracic cavity, which is going to lead to inspiration. Whereas when the diaphragm bows upwards, this is going to create a positive pressure within the thoracic cavity, causing expiration. And we're going to take a closer look at pulmonary ventilation in the coming slides. Now, before we go on to talk more about pulmonary ventilation, we need to make some mentions about atmospheric pressure. Atmospheric pressure, as the name implies, is the pressure of the atmosphere sitting on top of your body. And so the atmosphere is made up of gases, and there's about 14 or 15 miles of these gases sitting on top of your body right now if you're sitting at sea level. So if you're at sea level, we say that you're at a pressure of 1 atm, or 1 atmosphere. And 1 atmosphere is also equivalent to 760 millimeters of mercury, and we call that sea level pressure. And so remember, you've probably seen the units millimeters of mercury when we were measuring systolic pressure, which was only 120. So in this case, atmospheric pressure is much greater than systolic pressure. So if we're at 1 atmosphere, we're at 760 millimeters of mercury. But sometimes it's actually possible to be at 2 atmospheres. For example, if we put somebody into a locked chamber and we pressurize that chamber with a greater amount of air than normal, it's possible to bring them up to 2 atmospheres. And 2 atmospheres would simply be 760 times 2, which equals 1520 millimeters of mercury. The other thing I should point out is that air is not the only thing that can generate pressure on the body. Water can as well. And so imagine the last time you went snorkeling or swimming down at the beach. If you swam down anywhere below 10 feet, you probably felt a tremendous amount of pressure. And the reason you felt this tremendous pressure is that water is much more dense than air, and so exerts a greater pressure upon the body. And this really comes to light when you think that if you swim to 33 feet in depth, that pressure at 33 feet is equivalent to an entire additional atmosphere. So if you're at 33 feet, you have added an atmosphere of pressure to your body, and you still have another atmosphere sitting on top of that because the water has regular good old atmospheric pressure on top of that. So if you're at 33 feet underneath the water, we say that you are at 2 atmospheres of absolute pressure. Now that we've learned a little bit about pressure, we should go on to talk about Boyle's law. Boyle's law is one of the first laws of physics that applies to respiration. And Boyle's law says specifically that the pressure and volume of a gas are inversely correlated. Now, if that doesn't make sense, we'll give some examples. So take a look at the picture down the left-hand side of your screen. We have here a cylinder that is filled with about 1 liter of air. And if you don't want to think of a cylinder, just think of a 1 liter plastic bottle that's just filled with air, and that we put a cap on that bottle to make sure the air can't get out. Now imagine that I'm able to compress that 1 liter plastic bottle down to half its original volume, as you see at the right. If I compress it to half its original volume, the pressure within that air is going to be twice as great. And so basically, by reducing the volume, I've increased the pressure. And the converse is also true. Imagine that I have a 1 liter cylinder of air, and that I'm somehow able to stretch that cylinder out until it's twice the original volume. By doing that, I actually reduce the pressure of the air that's inside that cylinder. And so Boyle's law again states that pressure and volume are inversely related. As the volume decreases, pressure will increase. And as the volume increases, pressure will decrease. And so Boyle's law is important because it explains how the process of pulmonary ventilation takes place. So just remember that normal atmospheric pressure is 1 atmosphere, or 760 millimeters of mercury. So right now you have 760 millimeters of mercury of air sitting around your body. Now when you're not breathing, the pressure within your thoracic cavity is also 760 millimeters of mercury, and so these pressures are approximately equal. Now let's look at the bottom picture. What happens when you inhale? When you inhale, your diaphragm bows downwards, and this affects the volume of your thoracic cavity. Your thoracic cavity has actually grown in size. And so as the volume of the thoracic cavity increases, what happens to the pressure? If you said decreases, you're correct. Remember that Boyle's law states that as the volume of a closed container increases, the pressure within that container will decrease. And that's exactly what happens. We go from a pressure of 760 within the thorax to a pressure of about 758. And this negative pressure basically creates a vacuum that helps to pull air in through the nose, the mouth, the trachea, and eventually the bronchi until that air reaches the respiratory zone. So in the previous slide we said that inspiration was the movement of air from the outside through the nose into the trachea and into the lungs, and it occurs because the diaphragm bows downwards, increasing the thoracic volume, thereby creating a negative pressure. And so inspiration is an active process in that we need the diaphragm to contract and increase the volume of the thoracic cavity. On the other hand, expiration, or breathing out, is normally a passive process. That means we don't actually have to contract a muscle, we just have to relax one in order for it to occur. And so expiration occurs when your diaphragm begins to relax. And because of the elasticity in your lungs and the thoracic cavity, the volume automatically shrinks back to normal, which helps to force out that air out through your nose and out through your mouth. Now, this doesn't apply to forced expiration. Forced expiration is something we don't usually do in normal breathing, but it is something we do when we speak, when we sing, and especially if we're playing a wind instrument. That is an instrument you have to blow on. And so this forced pressure of air coming out doesn't come from the elastic recoil of our lungs. This additional pressure comes because our abdominal muscles are applying pressure to the abdomen, which is being transmitted to the thoracic cavity. And so your abdominal muscles are especially important for helping to generate forced expirations, which are useful in singing, talking, and also playing musical instruments. Okay, this slide just gives a nice, concise summary of the processes happening during pulmonary ventilation. During pulmonary ventilation, we have 2 processes occurring: inspiration, which is the movement of air into the lungs, and expiration, which is the movement of air out of the lungs. And so inspiration occurs because the diaphragm contracts, thereby increasing the volume of the thoracic cavity. This creates a slightly negative pressure relative to the outside, and as a result, the air rushes in through the nose, the mouth, the trachea, and the larynx into the lungs. Remember that expiration is normally a passive process. The diaphragm basically relaxes, goes back to its normal position, and in doing this, it reduces the size or volume of the thoracic cavity, which helps to force air out of the lungs back into the atmosphere. So in the previous slides, we talked about one of the very important processes that is important to respiration. That is pulmonary ventilation, the movement of air into and out of the lungs. There are three different physical factors that can influence the ease of air passage and the amount of energy required for this pulmonary ventilation to take place. And these include airway resistance, alveolar surface tension, and also lung compliance. And we're going to talk about each of these in some detail. Okay, so one of the factors affecting pulmonary ventilation is simple airway resistance. So resistance is anything that impedes the flow of air through our conducting zone structures to the respiratory epithelium. And so gas flow tends to decrease as resistance increases. And as it turns out, the greatest resistance is normally going to be found within the bronchi. The bronchi, remember, were those tubes that branched off the trachea. And they do seem like they're very large in diameter, but in fact they're the area where we can have the greatest resistance. For example, if somebody's having an asthma attack, they have what we call bronchoconstriction. Basically, the airways within the bronchi become inflamed, which reduces the lumen, and as a result, people that are having an asthma attack have to breathe much more forcefully to get sufficient amounts of air down to the respiratory zone. And so oftentimes we call these diseases where we have bronchoconstriction COPD diseases, and COPD stands for chronic obstructive pulmonary disease. Another factor that can affect pulmonary ventilation is alveolar surface tension. Remember, alveolar surface tension happens because the alveoli are themselves very thin, delicate membranes, and they're also very moist. And so the tendency with water is that these membranes want to stick together, and that would greatly reduce the passage of air into our alveoli. And so remember, we have those type 2 surfactant cells that produce the soap-like molecule that prevents those alveoli from collapsing. But depending on the amount of surface tension we have in the alveoli, this can affect the resistance or movement of air into the respiratory membrane. So just like bronchoconstriction could reduce gas flow, increased alveolar surface tension can also reduce gas flow. Another factor that affects the pulmonary ventilation is the compliance of the lungs. The compliance is basically the elasticity of the lungs. Imagine if I take a great big breath in and I let it out. I don't really have to generate much muscular pressure to force that air out. The lungs have this natural tendency to recoil back to their original volume, and that really helps with pulmonary ventilation. On the other hand, if I have a disease like, let's say, tuberculosis, where I get scar tissue within the lungs, this is going to greatly affect the stretchability or elasticity of the lungs. And so we're not going to be able to move as much volume of air in and out of the lungs because they're not as compliant. Other diseases that can affect compliance to the lungs include things like pulmonary edema, simple fluid in the lungs, and also paralysis. Now, one of the ways we can evaluate the function of the lungs and also compliance is through something called spirometry. Spirometry is the process of measuring various lung volumes, and these include something called tidal volume. The tidal volume, or TV, is the amount of air that you can move in and out of your lungs during normal quiet breathing. Now think about what proportion of your total lung capacity you use to breathe while you're sitting there at your desk. Probably not very much. For most of us, it's around 400 to 600 milliliters. On the other hand, inspiratory reserve volume, or IRV, is the amount of air that can be inhaled above and beyond a normal quiet breath. So sitting there at your desk, I want you to take a normal inhalation in, just a little one. Now, I want you to hold it and then try to take a bigger breath on top of it. How much greater do you think that breath was? Well, as it turns out, for most of us, the inspiratory reserve volume is a fairly large volume, somewhere around 2 to 3 liters. On the other hand, expiratory reserve volume is the amount of air we can exhale beyond a normal quiet exhalation. So sit there at your desk, take an inhale, exhale, hold it, now exhale everything else that you have. And it should become quite painful. And if you do this a few times, you'll probably realize that your expiratory reserve volume is not nearly as large as your inspiratory reserve volume. For most of it's around 1,000 to 2,000 milliliters. And finally, there's something within the lungs called residual volume. The residual volume is the volume of air within the alveoli that we can't normally breathe in or out. It's basically there holding our alveoli open. Now, in rare circumstances, it is possible to breathe out a little bit of that residual volume, but it's usually not voluntary. If you've ever been struck really hard on the back and felt like you've had the wind knocked out of you, chances are you've temporarily lost a little bit of that residual volume, which resulted in some pain and disconcerting feelings in your chest until you got that air back into your lungs. Okay, the last thing we're going to talk about is something called minute respiratory volume, or MRV. And this is basically just the volume of air that you're moving in and out of your lungs in a single minute. And so you can imagine if you're breathing 15 times in a minute, and that each of those breaths is, let's say, 500 mils, you would have a minute respiratory volume of 7.5 liters, or 7,500 milliliters. And so your minute respiratory volume can vary greatly depending on whether you're resting and relaxing or you're exercising. If you're exercising, you may start running something like 20 to 25 liters of air through your lungs in a single minute, whereas if you're just sitting here at your desk, you may only need 5 liters of air per minute. So minute respiratory volume is greatly dependent on our oxygen needs and exercise. Okay, in addition to the lung volumes, which must be measured, there are also something called lung capacities. Lung capacities differ from the volumes we talked about in the previous slide, in that we can calculate them. We don't actually measure them in most cases. The first of these is inspiratory capacity, which is basically just our tidal volume plus our inspiratory reserve volume. And then we have something called the functional residual capacity, or FRC, which is our residual volume plus our expiratory reserve volume. And finally, the most important thing we're going to talk about is something called the vital capacity. The vital capacity is the total amount of air that you can move in and out of your lungs. So imagine taking a huge, ginormous deep breath and then blowing all of that back out until it was completely painful. That would be giving off your vital capacity. And the vital capacity for most of us is going to be around 3 to 4 liters. And vital capacity differs mainly with height. So the taller somebody is, the greater vital capacity they will have. And this is why swimmers that have very long torsos are going to be very good at holding their breath and also swimming, because they have this huge vital capacity. Whereas little short people tend not to be very good swimmers because they don't have a very large vital capacity. The last capacity we're going to talk about is the total lung capacity, which is simply the vital capacity plus the residual volume. It's not actually possible to measure the residual volume through spirometry tests, but we can measure it through looking at x-rays and things like that. So this graph is called a spirograph, and the spirograph gives an example of the different respiratory volumes and capacities we talked about in the previous slide. So here you can see the tidal volume, which is just a small amount of your total lung volume, and it's the amount of air you move in and out of your lungs with a normal quiet breath. Then we look at something called the expiratory reserve volume. The expiratory reserve volume was the amount of air we can exhale beyond a normal quiet breath. And then we have the inspiratory reserve volume. The inspiratory reserve volume was the amount of air we could inspire beyond a normal inhalation. And then finally we have the vital capacity. The vital capacity was the total amount of air that we can voluntarily move into and out of our lungs. And for most of us, it's going to be somewhere between 3 and 5 liters. So in case you ever wanted to know, here are the averages for the various volumes and capacities that I just talked about. Don't worry, you're not really going to need to know these for the exam, except that you should probably know that tidal volume is around 500 to 600 mils, and vital capacity is usually around 3 to 4 liters, and it depends greatly on height. But the rest of them you don't need to memorize, but they're here in case you ever want to consult them. Now the next thing we need to talk about is something called anatomical dead space. The anatomical dead space is basically the volume of the air that we inhaled that is not reaching the respiratory zone. For most of us, this volume is around 150 milliliters of air, and this is residing principally in the trachea and a little bit in the bronchi as well. Remember that these conducting zone structures don't actually exchange any gases at all. So even though we've inhaled, let's say, 600 mils of air, not all of that air is going to reach the respiratory zone. And so if only 450 mils of air reaches the respiratory zone, this is the air we're actually going to use to exchange gases between our pulmonary capillaries and between our alveoli. The rest of it is stuck up in the trachea, and it can't be used for gas exchange. And so that's why we call it anatomical dead space. Now, as I said previously, we will often measure the various lung volumes for people when they're in the hospital, particularly if we are worried that they have some kind of respiratory disease. And so spirometry was just a process of measuring somebody's vital capacity, their expiratory reserve volume, and to do that we use something called a spirograph. And it might look something like the spirometer that we had in the previous slide, but chances are in the hospital it's going to be a very computerized mechanical thing. The other thing we can measure is something called the forced expiratory volume or forced expiratory capacity. And this measures the amount of air you can move out, but also how quickly you can move it out. And so, for example, if you're ever given this test, they'll give you a little device and you'll blow into it and try to empty out your lungs as quickly as possible. And in doing this, they can see whether your lung volumes are normal, and also they can see whether there's more resistance than there should be. If there's more resistance, it's going to take you a longer time to evacuate your entire lung volume. And so we see people that have increased forced expiratory capacity times if they have some kind of obstructive pulmonary disease that's basically impeding the flow of air through the bronchi. Okay, now that we've talked about the process of pulmonary ventilation, we need to talk a little bit about the composition of that air that we're breathing in. Most of you know that we obviously need to get oxygen out of the air, but most people don't know exactly how much oxygen is in air. Well, the answer is around 20.8, 20.9%, and we can just round this off to good old 21%. The other gas that makes up air is nitrogen. Nitrogen makes up around 78.6% of air, and we'll just call that 79%. So oxygen and nitrogen together make up the majority of air. And CO2, on the other hand, carbon dioxide, only makes up a fraction of 1%. That is, 0.04% of air is made up of carbon dioxide. Now, two of these gases are very important for respiration. Oxygen, obviously, is needed by the cells in our body to break down food and extract energy from it. And CO2 is a waste product that is produced in that process, and we need to get it out of the body because it can become very poisonous or toxic at low levels. Nitrogen, on the other hand, is a gas that, for all intents and purposes, is normally inert in the human body. That is, it is absorbed, but it is not used or metabolized. It is just excreted from the body with every exhaled breath. The only exception to this rule is that during diving, we can actually have nitrogen absorbed in the bloodstream and absorbed into the brain and doing some very funny things. So from the last slide, you should have taken away that the air is made up mainly of nitrogen, 79%, and oxygen, about 21%. And so each of these gases comprise a large proportion of atmospheric pressure. And Dalton's law of partial pressure states that each gas in a mixture of gases exerts its own pressure, and the total pressure is the sum of all the partial pressures. So to figure out the partial pressure of a gas in a mixture, you simply need to know the total atmospheric pressure as well as the percent. And so one of the things I would like for you to do is calculate the partial pressure of oxygen, nitrogen, and carbon dioxide at sea level. Okay, think about oxygen. What is the percentage? It's 21%. Now we have to represent 21 as a decimal, so it becomes 0.21. And we multiply that by total pressure of the atmosphere of 760 millimeters of mercury. And if you do that math, you should get around 159.6 millimeters of mercury, and we'll just round that off to 160. So we can say that oxygen has a partial pressure of 160 millimeters of mercury. Now let's do the same thing for nitrogen. Nitrogen has a percentage of 79, and we denote that by 0.79 as a decimal, and we multiply that by 760. If you do the math, you should find out that nitrogen has a partial pressure of about 699 millimeters of mercury, and we'll just average that off to 700. And finally, carbon dioxide is normally found at 0.04% in the atmosphere, and to convert that into a decimal, we actually have to go back two places. So it becomes 0.0004 times 760, and we should see that the partial pressure of carbon dioxide is around 3 millimeters of mercury. Now, you might be asking yourself at this point, why is he talking about partial pressure? Why is partial pressure important? The reason that partial pressure is so important is that in physiology, it is the partial pressure of a gas rather than its absolute percentage that determines whether or not it's life-supporting. For example, if I were to ask you, what percentage of oxygen do you need to live? You'd probably say 21%. Well, as it turns out, you can get by with a little bit less than that at atmospheric pressure, maybe 16 or 17%. But the answer to that question will differ depending on the total atmospheric pressure. Let's think about somebody that's in an airplane. Airplanes have normal, everyday air inside of them, around 21% oxygen. And as you go up in elevation, the pressure within that cabin doesn't change very much because the cabin is pressurized. And so normal, good old everyday air is enough to keep your cells oxygenated at adequate levels. Now think about what happens if cabin pressure is lost. Well, the first thing you're going to say is those little oxygen masks drop down. But why do they drop down? So let's do a math problem. Imagine that you are at 30,000 feet, which is equivalent to 222 millimeters of mercury of atmospheric pressure. What percentage of oxygen is required to reach a PO2 of 122? And 122 in this case is something that is the minimum necessary to keep you alive. And so in order to do this, I have a special equation, and this equation is set up at the right-hand side of your screen, and it's called the pressure T. And basically, it's not really an equation at all, but it's a way to figure out the equation for the problem you're trying to solve. So look at the problem here and ask yourself, what do we know and what are we trying to find out? Well, we know the atmospheric pressure, that's 222, and we know the partial pressure of oxygen, that's 122. So what are we trying to solve for? I see. We're trying to solve for the percentage. So in this case, you simply put your finger over the thing we're trying to solve for. So we put our finger over percentage, and then as a result, the answer to this equation is that percentage equals partial pressure over total pressure. So in this case, the solution becomes the partial pressure of oxygen over the total atmospheric pressure. So that would be 122 over 222. And so divide that out on your calculator and see what you get. Your answer should be around 0.55 or 55%. And what this means is you would need 55% oxygen to keep you alive at an atmospheric pressure equivalent to 30,000 feet. And this is why it's very important to listen to the instructions of the stewardesses on the airplane, because you only have maybe 30 seconds to a minute to get that mask on your face once the plane has lost cabin pressure. If you don't do that very quickly, you're going to pass out, and if you stay passed out in that low oxygen concentration for long enough, you will in fact die. And this is why it's very important to listen to what the stewardesses say when they tell you to put your oxygen mask on first before helping your kids with their oxygen masks, because you can black out very, very quickly within a matter of seconds once the cabin pressure is lost. And this is why it's very important to listen to the stewardess when they say, get your mask on as quickly as possible and then help your kids or other people with their own masks. Because as it turns out, we only have a few seconds to minutes of consciousness once that plane loses cabin pressure before we're going to black out. And in that case, we're not going to be able to put on our oxygen mask at all, and we're going to die. So we don't want that to happen. Now let's take a look at another question. We have a diver here, and he's at 300 feet underneath the ocean. And you should remember that 300 feet is equivalent to 9 atmospheres. So 300 divided by 33 equals 9, but you also have to remember that there's one additional atmosphere of pressure on top of that diver, and that's just the atmosphere of air that's sitting on top of the ocean. So in total, this diver is at 10 atmospheres, or 7,600 millimeters of mercury. And I'm asking you the same question I did before. What percentage of oxygen do we need to keep this diver alive? And we're in fact going to try to reach a partial pressure of oxygen of 160 millimeters of mercury, which is equivalent to what it normally is at sea level. And so what are we trying to solve for here? Well, we know atmospheric pressure, that's 7,600, and we also know the partial pressure, and that's 160. What are we trying to solve for? Percentage. Put your finger over percentage on the screen, and you see that the equation is that the percentage will equal the partial pressure over the total pressure. So in this case, the percentage would equal 160 over 7,600. So do the math on that real quick and find out what that comes out to be. Okay, you should get something on your calculator that says 0.021. And remember that as a decimal. To convert it to a percentage, you multiply by 100, and you're going to find out that that diver could breathe 2.1% oxygen, and that would be enough to keep him alive and happy at a depth of 300 feet. And that's because we can get to that 160 that we're at sea level for oxygen, even with a low concentration of oxygen. So the gist of these slides are that it's not the percentage of oxygen that determines whether or not it will sustain life. It is in fact the partial pressure. And so there's two different ways we can get an acceptable partial pressure. We can either have a low atmospheric pressure and a lot of oxygen, or we can have a little oxygen and a lot of pressure. By now you should figure out that we can increase the partial pressure of a gas by increasing its pressure. And we can use this knowledge to our advantage through something called hyperbaric oxygen treatment. Remember, the prefix hyper means greater than, and baric refers to pressure. So hyperbaric oxygen treatment is oxygen that's delivered under greater than normal pressure. And in this case, we tend to put somebody in a plastic or plexiglass tube, and we pressurize it with a high percentage, let's say 100% oxygen, to something like 2 atmospheres. Now, if they're breathing 100% oxygen at 1 atmosphere, think about what the partial pressure of oxygen would be. It would simply be 1 times 760. So they would be at 760 millimeters of mercury of oxygen. But if I'm able to pressurize them to 2 atmospheres, all of a sudden they're at 1520 millimeters of mercury. So a much greater oxygen partial pressure than they would ever encounter at sea level. And this can help them to recover from diseases such as certain types of bacterial infections that are very resistant to antibiotics. It can help to treat things like gangrene. It can also help to promote wound repair in otherwise healthy people. So if you imagine some of these A-list celebrities that go off and get very expensive plastic surgery on the weekends, yet you never see them walking around with these plastic surgery scars or anything like that. And that may be because some of these people are getting treated with hyperbaric oxygen, which can accelerate the healing process up to 2 to 3 times. So it can help you heal very, very quickly. The other thing we can use hyperbaric oxygen for is to treat people that have decompression sickness, or the bends. And that applies mainly to divers or people that have been working underwater and so forth. But either way, we need to think about something called oxygen toxicity. That is, that oxygen, when delivered at greater than normal atmospheric pressure, can become toxic. And it tends to become toxic once we get to 2 atmospheres or above. So here this person is in a tube, they're at 2 atmospheres, they're feeling fine. But if you get much beyond that, it's possible to get neurological symptoms where they seizure or even convulse, and these symptoms can be very acute, and they can also be very fatal. And so we try to avoid treating people at high percentages or high pressures of oxygen for long periods of time, because we can get this acute central nervous system oxygen toxicity. Now, this doesn't apply for our patients that are breathing 100% oxygen off the bottle in the hospital because, again, they're just at 1 atmosphere, and so they're only getting 1 atmosphere of oxygen. It primarily applies to people that are getting pressurized oxygen in a hyperbaric chamber. Okay, we've talked about Dalton's law of partial pressures. We've also talked about Boyle's law, that is the comparison of volume and pressure within a gas. Now we're going to learn a third law, which is Henry's law. And Henry's law states that the quantity of gas that will dissolve in a liquid depends on the amount of gas that we have, as well as its solubility coefficient. And so each of these 3 gases, carbon dioxide, oxygen, and nitrogen, have different solubility coefficients. Starting with nitrogen, nitrogen is the least soluble of the 3 gases. It has a low solubility in blood unless we're under pressure. And unless you're talking about somebody that's diving underwater and breathing compressed air, there's not a whole lot of nitrogen that will dissolve in the blood. Oxygen, on the other hand, is pretty soluble, and that's good because we can dissolve a little bit in our blood plasma, but as it turns out, most of it is going to be transported by hemoglobin. On the other hand, CO2 is quite soluble in liquids. Because of its molecular structure, we can dissolve a whole lot of carbon dioxide in a little bit of liquid. And you can witness this if you've ever opened up a Coca-Cola bottle after you've shook it up a bunch. Then you can see just how much carbon dioxide we can store in such a small quantity of fluid. And this is one of the reasons why we make sodas out of carbon dioxide rather than oxygen or nitrogen, is because carbon dioxide is much more soluble in the fluid, and we're able to get much more into there to give you that nice fizzy experience of drinking a Coke. Okay, now that we've learned about Henry's law and Dalton's law, we're going to go back to talk about the process of respiration. And respiration, if you remember, is divided into 2 processes: external respiration, which is the exchange of gases between the pulmonary capillaries and the alveoli, and internal respiration. This is the exchange of oxygen and carbon dioxide between the cells of the body and the systemic capillaries. So external respiration, once again, was the movement of carbon dioxide from the pulmonary capillaries into the alveoli and of oxygen from the alveoli into the pulmonary capillaries. And the gases move in these directions because of their partial pressures and also their concentration gradients. Oxygen is normally more concentrated in the alveoli, so it tends to move from an area of high concentration to an area of low concentration, that is the pulmonary capillaries. Whereas the blood in the pulmonary capillaries has a lot of carbon dioxide, and so this tends to move from an area of high concentration to an area of low concentration, that is, from the pulmonary capillaries into the alveoli. And so the efficiency of external respiration is determined by three different factors: the partial pressures and gas solubility coefficients, something called ventilation perfusion coupling, and also the structural characteristics of the respiratory membrane. Okay, another factor that affects the efficiency of external respiration is the alveolar partial pressures of carbon dioxide and also of oxygen. Now, due to the mixing of old and new air, the alveolar partial pressures are different than that of normal air. For example, the partial pressure of oxygen is around 105 versus 159 in normal air, whereas the partial pressure of CO2 is actually elevated. The partial pressure of CO2 is usually 40 in the alveoli versus 0.3 within the normal air that we're breathing. So deeper breathing is going to increase the amount of alveolar ventilation, and that's going to reduce the partial pressure of CO2 and increase the partial pressure of O2. Now again, you don't need to memorize the partial pressures of oxygen and carbon dioxide within the pulmonary capillaries or within the alveoli. You just need to know that the partial pressure of oxygen is highest in the alveoli and lowest within the systemic capillaries. By the same token, you need to know that the partial pressure of carbon dioxide is highest in the pulmonary capillaries, and that's why it diffuses easily from the pulmonary capillaries into the alveoli. Now, in case you ever want to know what the exact partial pressures are throughout the circulatory system, you can consult Table 22.4 in your textbook. A final factor that affects the efficiency of external respiration is something called ventilation perfusion coupling. Now remember that ventilation was simply the movement of air in and out of the alveoli of the lungs, whereas perfusion was the supply of blood to a body tissue or organ. Now within the lungs we tend to coordinate the supply of blood, that is perfusion, to only go to the best ventilated alveoli. As it turns out, not all alveoli are equally ventilated. So this process is called ventilation perfusion coupling, and it's a means of autoregulation. Remember, auto meaning self. And so we're able to regulate the amount of blood that goes to the alveoli based on how well those alveoli are ventilated. So let's take a look at an example. Here we have an alveolus that is initially very well ventilated. As a result, it has a very good blood supply or good perfusion, and that means that we're going to easily exchange oxygen and carbon dioxide across this alveolus. Now let's imagine that that same alveolus has suddenly become plugged with mucus or snot. How is that going to affect the perfusion of the alveolus? Well, after becoming blocked, we can expect to see the partial pressure of oxygen go down within that alveolus as it is absorbed by the pulmonary capillaries. By the same token, we can also expect the partial pressure of carbon dioxide to increase as we drop off more carbon dioxide in the alveolus that can no longer be ventilated. This increase in CO2 and decrease in O2 within the alveolus is going to result in reduced perfusion. That is, the arterioles that are feeding the alveolar capillaries are going to constrict, and this is going to reduce perfusion to the alveolus. So the net effect here is that we're going to see a reduced perfusion of blood to alveoli that are blocked or improperly ventilated. Now let's look at another example. Let's imagine that we had an alveolus that was previously blocked, and because it was previously blocked, we would expect to see an increased amount of CO2 and a decreased amount of O2 within this alveolus. These would result in reduced perfusion to that alveolus. Now let's imagine that that alveolus had suddenly become unblocked. What's going to happen? Well, after we unblock that alveolus, the ventilation is going to increase. And because ventilation increases, that's going to lead to an increase in the partial pressure of oxygen and a decrease in the partial pressure of carbon dioxide. This increased oxygen and decreased CO2 within the alveolus is going to lead to a dilation of the arterioles feeding the pulmonary capillaries that supply that alveolus. As a result, we can expect to see increased perfusion of this now well-ventilated alveolus. And so ventilation-perfusion coupling is a way that the body can adjust the blood flow to the alveoli of the lungs. They can make sure that they shunt the blood to the alveoli that are well ventilated, and they divert the blood from the alveoli that are not well ventilated. And this helps to make sure that the process of external respiration is as efficient as possible. So in comparison to external respiration, which happened between the alveoli and the pulmonary capillaries, the process of internal respiration is much simpler. Remember that internal respiration is the exchange of gases between the systemic capillaries and the body tissues. Because carbon dioxide is more abundant in the body tissues, it tends to diffuse from the tissues into the pulmonary capillaries. And because oxygen is least abundant in the tissues, it tends to diffuse from the systemic capillaries back into the tissues. So now that we've talked about the processes of external and internal respiration, we now need to discuss how we get the gases to the places where they need to go. You should remember that hemoglobin is responsible for transporting the majority of oxygen within the bloodstream. That is, around 98.5% of oxygen is transported by the hemoglobin molecules found within red blood cells. Another 1.5% is actually transported dissolved in the blood plasma. So the big picture here is that most of the oxygen is in fact transported by hemoglobin by the following chemical reaction. Basically, hemoglobin binds to O2 and becomes oxyhemoglobin. It also gives off a hydrogen ion, and this process happens in the lungs during external respiration. The reverse process happens within the tissues. That is, we have oxyhemoglobin that dissociates into hemoglobin plus free oxygen, and this free oxygen diffuses from the systemic capillaries into the tissues where it supplies the cells with the oxygen they need for their own metabolism. It's important to realize that each hemoglobin molecule has 4 iron atoms on it that can bind with up to 4 oxygen atoms. And so we can measure the percent saturation of hemoglobin by looking at how many O2 molecules each hemoglobin molecule carries. For example, if we have a hemoglobin molecule that is carrying 4 oxygen molecules, we say that that hemoglobin is 100% saturated. On the other hand, if we have a hemoglobin molecule that's only carrying 1 oxygen molecule, then we say it is 25% saturated because there are 3 remaining binding sites that are unbound with oxygen. Now, hemoglobin is actually a very, very smart molecule. And by saying smart, I mean that it has an ability to either hold on tightly to oxygen or be very giving with oxygen and let it go. And so it tends to adjust its greediness for oxygen based on the partial pressure of oxygen around it. So imagine what happens in the pulmonary capillaries. The pulmonary capillaries are exposed to a very high oxygen concentration, that is the oxygen coming from the alveoli. So in these situations, hemoglobin is going to grab a hold of and bind very tightly to oxygen and not let it go. On the other hand, when that hemoglobin gets to the systemic circuit, it's going to be surrounded by a relatively low oxygen environment. In this case, hemoglobin becomes very giving, and so very quickly can off-gas that oxygen and let it go into the surrounding tissues. Okay, so not only does oxygen have a role in determining the affinity that hemoglobin has for oxygen, but carbon dioxide also plays a role. Remember that carbon dioxide tends to be elevated in situations when oxygen is low. That is, carbon dioxide, for example, is really high within the systemic circuit because the tissues have generated a fair amount of carbon dioxide. So in these situations, the affinity curve of hemoglobin for oxygen will change. Basically, it will become depressed. So when we have high amounts of carbon dioxide, hemoglobin will tend to be more giving and let more oxygen off into the systemic capillaries. On the other hand, if we go to the lungs where there is a low concentration of CO2, hemoglobin tends to bind very tightly to oxygen and not want to let it go. And finally, a third factor that helps to determine hemoglobin's affinity for oxygen is the pH. Remember, the pH scale helps to measure the alkalinity or acidity of a solution. And so numbers below 7 tend to be acidic, and numbers above 7 tend to be alkaline. And so blood normally has a pH of around 7.4, which is just slightly alkaline. However, in situations where we have a low blood pH, hemoglobin tends to let go of a lot more oxygen. Whereas in places where we have a high blood pH, hemoglobin has a high affinity for oxygen and doesn't want to let it go. So you might be wondering what causes this shift in pH throughout the systemic and pulmonary circuits. Well, as it turns out, the more carbon dioxide we have dissolved in the blood, the lower the pH will be. And remember, carbon dioxide tends to be high when oxygen is low. And so this is another way in which hemoglobin can gauge the relative oxygen concentration in the tissues by monitoring blood pH. Blood pH is typically lowest in situations where we have a high CO2 load and where the surrounding O2 is very low in partial pressure. So in essence, hemoglobin lets go of oxygen more readily in situations where there's a low pH and high CO2. So this slide just summarizes the factors that we talked about in the previous 3 or 4 slides. Basically, hemoglobin is a smart molecule that can adjust its affinity for oxygen based on the chemical composition of the surrounding environment. For example, if the partial pressure of oxygen is high, hemoglobin tends to be very greedy and not want to let oxygen go. Whereas the partial pressure of oxygen is low, for example, in the systemic tissues, a hemoglobin becomes very giving and readily off-gasses oxygen. The affinity of hemoglobin for oxygen is also affected by the CO2 concentration. So when the CO2 levels are very high, for example in the systemic loop, hemoglobin tends to let go of oxygen much more readily. Whereas when the partial pressure of CO2 is low, that is within the lungs, hemoglobin here tends to be very greedy and hold on to oxygen. And finally, remember that the hydrogen ion concentration also has a role in determining hemoglobin's affinity for oxygen. The hydrogen ion concentration is higher in areas where we have a low pH, and low pHs are typically caused by an abundance of carbon dioxide. And so at a very low pH environment, hemoglobin tends to be very giving and let go of oxygen readily. Whereas in a high pH environment, hemoglobin tends to be very selfish and hold on to all the oxygen that it has. So I've now color-coded the situations where we might expect O2, CO2, and hydrogen ions to have a role in the affinity of hemoglobin for oxygen. Remember that we said that if the partial pressure of oxygen is high, hemoglobin is greedy and grabs a hold of and hangs on to all the oxygen it can get a hold of. And we typically find this situation within the pulmonary capillaries, whereas oxygen concentrations tend to be lower within the systemic capillaries, and as a result, hemoglobin readily lets go of oxygen. Same for CO2. The CO2 levels tend to be high within the systemic capillaries and low within the pulmonary capillaries, and so this also affects hemoglobin's affinity for oxygen. And finally, look at hydrogen ions. The hydrogen ion concentration tends to be high within the systemic capillaries, which makes hemoglobin let go of oxygen, and low within the pulmonary capillaries, where hemoglobin will readily grab a hold of and hang on to all the oxygen it can get a hold of. And so, in essence, hemoglobin is a smart molecule in that it adjusts its affinity for oxygen based on the needs of the surrounding tissues. We now need to talk about some homeostatic imbalances that are very important to the respiratory system. The first of these is hypoxia. Remember that hypo means lower than, so hypoxia means low levels of oxygen. And it results from inadequate oxygen delivery to the tissues and can often result in cyanosis. Cyanosis is blueness of the mucous membranes or the nail beds. So if you ever want to assess somebody's oxygenation and you don't have a pulse oximeter handy, you can simply take a look at the color of their nail beds and also apply a little bit of digital pressure to the surface of a fingernail. You should see the blood temporarily blanch and then come back bright pink. If it doesn't come back bright pink, or it comes back something like blue, it indicates that we might have somebody that is hypoxic. And so hypoxia can be divided into several different categories. We have anemic hypoxia if somebody has too few red blood cells, and that is they would have a reduced packed cell volume or hematocrit. Another example of hypoxia is ischemic hypoxia, and ischemic hypoxia is usually caused by impaired blood flow due to a blocked blood vessel. Another type of hypoxia is called histotoxic hypoxia. Remember that histo means tissues and toxic means something that is poisonous. So histotoxic hypoxia results when cells are unable to use O2 as a result of metabolic poisons. On the other hand, hypoxemic hypoxia, which is a mouthful, is caused by abnormal ventilation. For example, if we have somebody that has pulmonary disease and is not able to fully ventilate their alveoli, we may see reduced partial pressures of oxygen within their peripheral circulation, and this would be called hypoxemic hypoxia. The last type of hypoxia is caused by carbon monoxide poisoning. Carbon monoxide is a compound that is produced in the combustion of fossil fuels like gasoline. And we tend to see carbon monoxide poisoning in people that have been, let's say, running a generator in their carport or even within their house. And carbon monoxide is a tasteless, odorless gas that can very easily leak into the house and cause these very bright nail beds that we see in people with carbon monoxide poisoning. So instead of having blue nail beds, which are typically characteristic of hypoxia, we see that their nail beds are in fact bright red, and you would think, well, this may indicate very good oxygenation, but in this case we have carbon monoxide binding to hemoglobin and displacing the oxygen, and so these people are literally not able to pick up any oxygen in their lungs because the hemoglobin receptors for oxygen are bound up with carbon monoxide. Okay, now that we've covered oxygen transport, let's go take a look at how carbon dioxide is transported throughout the blood. Well, around 7 to 10% of CO2 is dissolved directly in the blood plasma. Remember that blood plasma was primarily water, and that water in fact can dissolve a fair amount of CO2 because CO2 has a very large solubility coefficient. On the other hand, about 20% of CO2 is actually transported by the hemoglobin molecule. That is, within the tissues we have high amounts of CO2 that bind to the hemoglobin to make something called carboxyhemoglobin. But once we get to the lungs, this carboxyhemoglobin will dissociate into hemoglobin plus free CO2, and that will allow us to expire that CO2 through the alveoli. The most important way that CO2 is transported is in fact through the bicarbonate ions. Now, bicarbonate ions are transported by the plasma, but they're actually created within the red blood cells. The red blood cells have a special enzyme that can combine CO2 and water to make carbonic acid, and they help that to dissociate into hydrogen ions and bicarbonate ions. These hydrogen ions and bicarbonate ions will diffuse into the blood plasma, and they will have a role in affecting the pH. Remember, I said previously that the higher the CO2 levels, the greater the amount of hydrogen ions, and therefore the lower the pH. And so we tend to see low pH blood within the systemic circuit where there's a lot of CO2 being generated by the metabolism of cells. So the big picture here is that the majority of carbon dioxide is in fact transported by bicarbonate ions located in the blood plasma. But it's important to remember that these bicarbonate ions were created through a special chemical reaction that actually happens within red blood cells. Okay, now we're going to talk about the neural mechanisms that regulate respiration. Respiration is controlled by the medulla oblongata and also the pons. Within the medulla oblongata, we're going to find two different neuron centers that control breathing. The first of these is called the ventral respiratory group. And the ventral respiratory group is responsible for generating the periodic motor nerve impulses that cause the diaphragm and intercostal muscles to contract. And it sends these muscles by the phrenic nerve and also by the intercostal nerves. And so when the inspiratory neurons of the ventral respiratory group fire, that causes the diaphragm and intercostals to contract, which causes inhalation. When the expiratory neurons within the ventral respiratory group fire, that's going to cause the relaxation of the diaphragm and also the external intercostals, and that's going to result in exhalation. The dorsal respiratory group, on the other hand, does not really generate motor nerve impulses, but it does receive sensory information from stretch receptors in the lungs. And these stretch receptors basically report back to the brain how full the lungs already are, and it's a way to prevent us from overinflating our lungs. So this information is relayed from the dorsal respiratory group to the ventral respiratory group, where it modifies how much inhalation and exhalation is going on. So in addition to the medulla oblongata, the pons is also quite important in respiration. So the pons has something called the pontine respiratory group, and this is a group of neurons that receive information from different areas of the brain, and basically they have input onto the ventral respiratory group, and so can modify the standard breathing rhythm. For example, they receive input from the cerebral cortex, and so they will modify breathing rhythms, for example, when you're excited, or when you're nervous, or when you're just trying to talk, so that breathing doesn't interrupt with these. So in a nutshell, the medulla oblongata is responsible for generating the periodic motor nerve impulses that cause breathing. But it is not making this decision all on its own. It's receiving input from the cerebral cortex, from the pons, from the stretch receptors in the lungs, and also from the chemoreceptors found within the carotid arteries and also the aorta. And of course it also receives input from the proprioceptors located in the joint capsules. So given all the input that the medulla oblongata receives, let's talk a little bit about how it's going to modify breathing rate and depth with each of these different stimuli. First, let's take a look at the partial pressure of carbon dioxide. Remember that carbon dioxide is a metabolic waste generated in the systemic circuit as our cells metabolize the food. And the more CO2 we have, generally the lower the O2 is. And so the respiratory system uses CO2 as a proxy for something indicating low O2. In a nutshell, anytime the CO2 is high, we are going to increase our breathing rate and also increase breathing depth. The other thing that can speed up breathing rate is the pH, or hydrogen ion concentration. Remember that as we add more hydrogen ions to a solution, the more acidic it gets and the lower pH number. And the one thing that contributes most to the acidity of the blood is going to be, of course, a higher partial pressure from carbon dioxide. And this is because carbon dioxide combines with water to make carbonic acid. And so the more acid that we have, the lower the pH will be. And just like with CO2, the lower the pH means more metabolic demand, which means that our respiratory system is going to increase the depth of ventilation and also the frequency of ventilation as well. Okay, factor number 3, oxygen. Obviously, we're going to increase our breathing rate and depth if our partial pressure of oxygen is very low. However, the surprising thing is that the respiratory system actually pays closer attention to carbon dioxide than it does to oxygen. We actually have to have a pretty major drop in the partial pressure of oxygen in order to increase the breathing rate, whereas we only need a minute increase in carbon dioxide to more than double the breathing rate. And so carbon dioxide seems to be the main factor that the respiratory system is focusing on for maintaining homeostasis. But normally this is okay, because when oxygen is high, carbon dioxide is low. And when carbon dioxide is high, oxygen is low. And so this is normally a good way to track how efficient our ventilation should be and whether or not we should speed up our breathing rate or increase breathing depth. The final factor that can affect breathing rate and depth is stimulation of the proprioceptors. Remember, proprioceptors were special sensory structures located within the joint capsules. And basically, when our joints start moving a whole lot, say if we're running or jogging, this will send sensory information to the medulla oblongata, which will cause us to speed up our breathing rate and increase our breathing depth. And basically, it's a way for the body to say, hey, my joints are moving, I must be exercising, we're probably going to need more oxygen pretty soon, so we probably want to start breathing more quickly and also more deeply. Okay, before we end this lecture, we're going to focus on a few homeostatic imbalances or diseases that affect the respiratory system. The first of these is COPD, which stands for chronic obstructive pulmonary disease, and we talked briefly about this earlier on in the lecture. These diseases result in an irreversible decrease in the ability to force air out of the lungs. As a result, people that have COPD must be breathing much more forcefully to move the same amount of air in and out of their lungs. So common features of COPD is a history of smoking. That is, 80% of the patients that have COPD diseases are smokers. Another common factor is dyspnea, which means labored breathing. If you ever watch somebody that has COPD when they're having an attack, you will see their chest heaving in and out in order to take enough oxygen and get rid of carbon dioxide. The other thing that's very common is coughing and frequent pulmonary infections. People with COPD frequently get pneumonia and other respiratory infections. Most of these developed as a result of hypoventilation, that is, lower than normal ventilation of the lungs. So an example of a COPD disease is emphysema, and emphysema is caused by permanent enlargement of the alveoli accompanied by a loss of elasticity of the lung tissue. Now, because the lungs have lost their compliance, somebody affected with emphysema must use a lot more muscular force in order to ventilate the lungs. Instead of just using the diaphragm, they're also using the intercostal muscles, and as a result, they're spending a lot of energy doing this. So people with emphysema will spend somewhere between 15 and 20% of their total calorie intake just breathing. The other thing that happens with emphysema is that the pulmonary capillaries begin to disintegrate, and this further reduces the oxygen carrying efficiency of the lungs, and can even lead to enlargement of the right ventricle of the heart. There is no cure for emphysema, but it is often treated by administering 100% oxygen. And of course, one way to prevent getting emphysema in the first place is to never smoke. Our next disorder is cystic fibrosis. Cystic fibrosis is the most common lethal genetic disease in the United States, and it's caused by an abnormal protein in cells that causes an overproduction and excretion of chloride ions. And this results in the accumulation of very thick, sticky mucus within the respiratory tract, which can clog the alveoli, leading to secondary infection, as well as leading to dyspnea or labored breathing. Until recently, people with cystic fibrosis basically had a limited life expectancy, somewhere between 12 and 30 years. Now, with increased treatments, which include inhalers and special percussive therapy, we're starting to see people living into their 40s and even 50s. Still, there's no magic bullet for curing cystic fibrosis, and most patients have to undergo percussive treatment several times a day in order to keep this sticky mucus from clogging up their air passages and alveoli. In the future, it's hoped that we can develop gene-based therapies that can help to treat or even cure people with cystic fibrosis. So another disease that affects pulmonary ventilation is asthma. Unlike COPD, which is chronic, asthma is acute. And asthma results in inflammation of the bronchi, and it's a result oftentimes of allergens that are present in the environment. And these allergens cause massive inflammation and swelling within the airways, which reduces the size of the lumen and makes it very difficult for people to breathe. And so symptoms of asthma include dyspnea or labored breathing, and asthma attacks can be triggered by allergens, cold, or a number of factors. And treatment for asthma typically utilizes inhaled medications such as albuterol and other anti-inflammatory steroids. About 1 in 10 people in North America suffer from asthma, and children tend to suffer from it more than adults. Okay, our last disease is tuberculosis, and tuberculosis is an infectious disease which is caused by the bacteria Mycobacterium tuberculosis. And this bacterium is spread by inhaling droplets that are coughed out from an infected person. And these droplets will enter the respiratory tract, and the bacteria will begin to multiply, and they will also be able to encysst themselves within pockets within your lungs. And they tend to have reoccurrences when people's immune systems are depressed. And so you probably don't know anybody that has tuberculosis in the United States, but it's not unheard of here, and it's very common in the third world. Your book says that on average, 1 in 3 people in the world actually is infected with tuberculosis, although many of them are not symptomatic. And tuberculosis is such a concerning disease because 1, it's on the rise, and 2, it's very difficult to treat. Even non-resistant forms take a full 12 months to treat with some very heavy-hitting antibiotics. And as with taking any drug for 12 months in a row, it's very hard on your liver, and people tend to not want to do it anymore, particularly after they stop exhibiting symptoms. And so we're starting to get several strains of drug-resistant and multi-drug-resistant tuberculosis that can be very, very fatal. Okay, you've reached the end of the lecture on the respiratory system. There won't be any review questions this week because it's getting up to the file size where I can no longer fit this on the Lima site. But if you did notice anything unusual about today's lecture, please email me and I will give you 1 point extra credit on your last exam. So you have to describe to me what was unusual about today's lecture.